Greetings from Indian Journal of Anaesthesia. I, Dr. Sharma, will be presenting an article published in the June 2024 issue of Indian Journal of Anaesthesia. The article is titled A Randomized Trial Comparing Block Characteristics of a Mixture versus Sequential Injections of Lignocaine and Ropivacaine for Supraclavicular Brachial Plexus Nerve Block in patients undergoing upper limb surgery. Lipid-soluble local anesthetics like ropivacaine and bupivacaine have longer duration of action and slower onset compared to intermediate potency local anesthetics like lignocaine, mepivacaine, and prilocaine. Combination of two local anesthetics are often used in regional blocks to combine their clinical properties, aiming for faster onset and longer block duration. Factors like total dose, pKa, drug deposition near the nerve, and use of additives affect the nerve block onset, while the role of volume and concentration remains unclear. While mixing two local anesthetics of different duration of action is common in clinical practice, literature on sequential injection of local anesthetics is limited. So the primary objective of this study was to compare the percentage of patients with complete sensory block at 10 minutes after the injection of mixture versus sequential injection of lignocaine and ropivacaine. The secondary objectives were percentage of patients with first sensory and motor block onset, percentage of patients with complete block till 30 minutes, block duration, total duration of sensory and motor blockade, analgesia duration, and complications. Institutional Ethics Committee approval was taken. The trial was registered in Clinical Trial Registry of India. The study was a randomized controlled trial which included adult patient 18 to 70 years old, 60 kg and above, planned for unilateral upper limb surgery. Patients excluded were patients who did not give consent, coagulation or bleeding disorder, local site infection, any nerve injury, neuropraxia, paralysis, history of allergy or anaphylaxis to ropivacaine or lignocaine, pregnant females, difficult or abnormal anatomy, and block failure due to technical reasons. After recruitment, patients were randomized by computer-generated random number table with allocation concealment done by sequentially numbered opaque sealed envelope. The patients and outcome assessors were blinded. The patients were allocated into two groups, Group M, that is the mixed group, and Group S, that is the sequential injection group. The block was performed in a block room adjoining OT before surgery. IV line was secured, 1 milligram midazolam was given for angiolysis. Ultrasound guided supraclavicular block was given with a high frequency linear ultrasound probe. After clean raping, 1 ml of lignocaine 2% with adrenaline 1:2 lakh was injected at the needle insertion area. The needle was inserted lateral to medial with a 22 gauge of appropriate length with in-plane approach. The drug was injected at the lower and upper point of the nerve cluster by two-point injection technique. Drugs used were lignocaine 2% with 1:2 lakh adrenaline, 15 ml, and 0.75% ropivacaine, 15 ml. In the sequential group, 15 ml of 2% lignocaine with ADR followed by 15 ml of 0.75% ropivacaine was given with the intent to surround lignocaine already deposited. 7.5 ml of each drug was given at 2 points of plexus. In group M, 30 ml of a mixture of both local anesthetics were deposited, 15 ml each in the lower, followed by upper part of the cluster. The sensory blockade was evaluated in a Likert scale of 1 equal to no sensation, 3 equal to normal sensation to pain prick in the areas of musculocutaneous nerve in the lateral forearm, median nerve in the palmar aspect of the second finger, radial nerve in the dorsum of hand between the thumb and the second finger, ulnar nerve in the fifth finger. Motor block was assessed in a Likert scale of 1 equal to complete paralysis and 3 equal to normal function. By elbow flexion, assessed the musculocutaneous nerve, wrist flexion assessed the median nerve, wrist extension assessed the radial nerve, and flexion of the fourth and fifth finger assessed the ulnar nerve. The study defined the onset of sensory or motor block as patients, percentage of patients with the sensory score of 1 or motor score of 1 in any of the 4 nerves. Complete sensory or motor block with percentage of patients with sensory score 1 or motor score 1 in all the 4 nerves. The block procedure time was time from insertion to removal of the needle. The duration of analgesia was time from completion of block to first request of analgesic by patient. The duration of sensory or motor block was time from completion of block till sensory score 3 or motor score 3 in all the 4 nerves. A failed block was declared when it needed to be converted to GA or required any supplemental block. So the primary outcome was percentage of patients with complete sensory block, that is score 1 in all the 4 nerves at 10 minutes post-injection. The secondary outcomes were onset and complete sensory block at 3, 5, 7, 10, 15 and 30 minutes post-injection. Onset and complete motor block at 4, 8, 12, 16, 30 minutes post-injection. The duration of analgesia, duration of sensory and motor block, block failure and complications between the two groups. The sample size was based on a study where the percentage of subjects with complete sensory block was 57% at 10 minutes post-injection of a mixture of local anesthetics in supraclavicular brachial plexus block. To be able to detect an increase in this rate to 90% at 10 minutes, assuming alpha error of 5% and 80% power, 27 participants were required in each group. Assuming 20% block failure, 30 patients were included in each group. The numerical data were expressed as mean and categorical data in percentage. Parametric variables were compared using unpaired t-test. Non-parametric data by Wilcoxon rank sum t-test. Categorical data by the Fisher's exact test and p less than 0.05 was considered significant. So in the results, ultimately 32 patients were analyzed per group. 1 patient in the group S required rescue block, whereas 1 patient in group M was converted into general anesthesia. The demographic and operative data and the baseline characteristics were comparable between the two groups. So this is the figure representing the percentage of patients with sensory score 1 in any of the 4 nerves, motor score 1 in any of the 4 nerves, and percentage of participants with complete 4 nerve sensory block and 4 nerve motor block. Here we find that the percentage of patients in the group S was significantly higher with complete 4 nerve sensory block at 10 minutes post-injection compared to group M. This difference persisted up to 30 minutes post-block. Similarly, at 16 minutes, the group S had a higher percentage of patients with motor block as compared to the group M. The duration of block and the block procedure time was similar in both the groups. So, previous research had mainly focused on using lignocaine and ropivacaine in regional nerve blocks, and recently the attention has turned to sequential injections also. In this study, the group M had a higher percentage of patients failing to achieve complete sensory or motor block compared to group S, possibly due to drug dilution, but this did not lead to block failure during surgery. The onset of first sensory and motor block was statistically insignificant between the two groups, which was similar with data from previous studies. The total block duration and analgesia duration is similar between the two groups, suggesting that the duration of action might be primarily related to the total local anesthetic dose regardless of the injection technique. The time to perform the block also did not significantly differ between the two groups despite more needle path changes in the sequential technique. No complications were reported in either group. The limitation was the study was that they did not compare a single agent in a separate group. Further studies could incorporate a third group receiving only ropivacaine for better control. Thus, from this study, it can be concluded that the sequential injection of lignocaine and ropivacaine initially yields a slightly higher rate of sensory and motor block onset compared to mixed injection. However, this diminishes after 30 minutes post-block injection, with both groups showing similar total duration of sensory and motor block as well as duration of analgesia. Thank you.